All right, good morning, everyone. Thank you to the organizers for the opportunity to speak about primary ciliary dyskinesia and heterotaxy-associated ciliary dysfunction. I have no disclosures. I hope that in the next 20 minutes or so, we can discuss the association between PCD and heterotaxy, review data supporting heterotaxy-associated ciliary dysfunction, and I will refer to that as HACD, discuss other non-ciliary respiratory complications, and review the respiratory evaluation and management in heterotaxy. And so I'd like to start with a clinical presentation from our center. This is a 17-month-old X33-weeker with right atrial isomerism and complex congenital heart disease. He is status post PDA stent and stage 1 biventricular repair at 6 months of age and stage 2 repair 2 weeks prior to consult. He was extubated at 48 hours post-op, and the course was complicated by chylous effusion and hypoxemia. An ultrasound of the chest revealed reduced motion of the right diaphragm, but the left was normal. His respiratory support at the time was heated high-flow nasal cannula at 15 liters per minute, 0.8 FiO2, and 20 parts per million of INO. The reason for the consult was persistent hypoxemia and the request for a flexible bronchoscopy for surveillance cultures. Airway clearance had been started by the primary team 1 day prior to the consult. On exam, his sats were in the mid-90s. He was tachypneic. He did not have significantly increased work of breathing, and lung auscultation revealed coarse bilaterally and somewhat diminished lung sounds at the bases. Some relevant clinical data on the left, it's his x-ray at the time. You cannot appreciate the lung fields very good from there, but he had some bilateral atelectasis, and his right diaphragm is elevated. The primary team had obtained a genetic congenital heart defects and heterotaxy panel that showed one heterozygous variant of unknown significance on the BRAF gene. We obtained a commercial PCD genetic testing, which at the time had 42 genes and came back negative. His ultrastructural defect was in the form of partial loss of outer dinane arms in less than 50% of the cilia, which would be a class 2 defect. His CT findings showed right lower lobe airspace opacity, a small residual pneumothorax, left-dependent atelectasis, and a note that he did not have bronchiectasis. His BAL grew Rautellia ornithinolytica, which is an encapsulated gram-negative rod from the family of Enterobacteria closely related to Klebsiella. So with this clinical presentation in mind, I'd like to give 3 overviews, and Dr. Lowe has referred to some of these. Ciliary dysfunction and heterotaxy converge in decreased mucociliary clearance, increased operative risk, and increased morbidity of lung complications. 2, the link between PCD and heterotaxy, although has been suspected for a long time, it wasn't actually made until 2007 via systematic studies. And the last one, there is PCD. There are patients with heterotaxy that do have PCD, but not all ciliary dysfunction in heterotaxy is due to PCD. And so just another overview of primary ciliary dyskinesia, inheritance pattern of mostly autosomal recessive. Demographics now known to be close to 1 in 7,500, so perhaps not as rare as once thought. The phenotype is that of daily wet cough starting in early childhood, neonatal respiratory distress, chronic otosino-pulmonary disease, subfertility, and bronchiectasis. And we now, hot off the press, have the new guidelines, which are joined between the European Respiratory Society and the American Thoracic Society, and were published this past September in the European Respiratory Journal. And they suggest that we use symptom-based tools to try to identify these patients who have a strong genotype and that should be evaluated for PCD. And these include the primary ciliary dyskinesia rule, better known as the Picadar score, the American Thoracic Society clinical criteria, which suggests 2 out of 4 signs and symptoms, and the ERS adult bronchiectasis guidelines. They prioritize genetic testing and ciliary ultrastructured for confirmed PCD, but give us ancillary tests like nasal nitric oxide, high-speed video microscopy, and immunofluorescence to use in the newly PCD highly likely categories, which we are very excited about. And so for these patients who have a strong clinical phenotype and whose genetic testing or ciliary ultrastructure is non-conclusive, but have one of these adjunct tests, could be classified into this category. They also provide suspected PCD, PCD unlikely, and PCD highly unlikely guidelines. And so let's look at PCD and heterotaxy. This is a study by Andrew Barber, Adam Shapiro, and others. It's a multi-center prospective study that looked at 559 participants with confirmed PCD. They stratified them based on their ultrastructural defects as well as their genotype. In this particular cohort, 50% of the patients had situs solitus, 39% had situs inversus totalis, and 10% had situs ambiguus. They defined heterotaxy in this group as patients with situs ambiguus with complex congenital heart disease, and found that in that 10% of situs ambiguous patients, 2.5% had heterotaxy. Laterality defects were more commonly found in the outer dynane arm defects, and 4.5% of patients within that group had heterotaxy, whereas none in the inner dynane arm microtubular defect group had heterotaxy. And so how do these patients with situs ambiguus fare out clinically? And so this was the purpose of this multi-center cross-sectional analysis of 397 patients who were 21 years of age or younger with confirmed primary ciliary dyskinesia. They divided the groups between situs ambiguous with or without heterotaxy and no situs ambiguous. And they found that for the situs ambiguous group, these patients had less or decreased pulmonary function, worse nutrition, and increased hospitalization and need for IV antibiotics for respiratory illnesses. And so Dr. Lowe talked about this, so I'm going to quickly review it. And so this is how did these patients with heterotaxy did in their post-op state. And so the patients with heterotaxy compared to those with congenital heart disease and no heterotaxy did worse for the post-surgical events of post-surgical death, ECMO requirement, tracheostomy, and prolonged ventilatory course. Why is that? And so the answer to that is not fully understood, but this study sheds light into it. She also talked about it, so I'm not going to repeat it, but essentially these patients with heterotaxy had a good percentage of them had ciliary dysfunction as demonstrated by low nasal nitric oxide as well as abnormal motile ciliary function. There are multiple other cohorts that have demonstrated similar findings of significantly increased ciliary dysfunction and low levels of nasal nitric oxide, but only a subset of these patients had met PCD criteria for diagnosis. And this suggests that there are alternative mechanisms for ciliary dysmotility or dysfunction in patients with heterotaxy other than PCD. We must remind ourselves that in heterotaxy, there are multiple other respiratory issues that are not primary ciliary dyskinesia or HACD. And these include recurrent respiratory infections secondary to immunosuppression or prolonged ventilatory state, sleep disorder breathing, bronchiectasis, which could be the result of immunodeficiency and or aspiration. Also, these patients can have lung diseases that are associated with their cardiac pathophysiology. Like for instance, in patients with Fontan physiology, these patients have a high incidence of plastic bronchitis and pulmonary edema. Patients with chronic pulmonary vasculopathy can have pulmonary hypertension and pulmonary embolism. Furthermore, airway anomalies are common in patients with heterotaxy. Up to 30% of patients with heterotaxy were found to have airway anomalies. The most commonly identified ones, depending on who you look at or which study you look at, are lower airway stenosis and tracheobronchomalacia, but others include subglottic stenosis and tracheal bronchus. In addition, these patients can have lung disease that is post-surgical and includes iatrogenic vocal cord dysfunction leading to chronic aspiration, ventilator-related lung injury, diaphragmatic paresis, etc. And so when should we be thinking about heterotaxy-associated ciliary dysfunction? And so these patients are going to have a similar phenotype than that of patients with PCD, perhaps milder and sometimes with some atypical features. But some of the symptoms to think about will be chronic wet cough, chronic nasal congestion, recurrent otosino-pulmonary infections, neonatal respiratory distress without a causative cardiac lesion, and I put a question mark in there because, at least for me clinically, that's very difficult to tease out what's what. Is it the heart, is it the lungs? And we all here know that that's a common point of discussion. Cerebral ventriculomegaly and hydrocephalus could be atypical presentations that we also see in primary ciliary dyskinesia. Unexpected prolonged post-op respiratory complications. And so when all these patients with a phenotype of PCD should be evaluated for PCD, and if the workup is negative, understanding that we're still learning about PCD, then we can make the suggestion or the working diagnosis that this is heterotaxy-associated ciliary dysfunction. And so how do we evaluate these patients? Hopefully there's been enough evidence here today to demonstrate that every patient with heterotaxy should be evaluated by a pulmonologist. When able, we should be getting lung function testing. And these patients with respiratory symptoms that meet the phenotype PCD criteria should be evaluated. Some would argue that all patients with heterotaxy and respiratory symptoms should be evaluated. And that's what we do in our center. Nasal nitric oxide measurement for patients that are 5 or older, and nasal nitric oxide measurement using tidal breathing for those that are 2 years of age or older, and of course PCD genetic testing and or ciliary ultrastructure evaluation. Knowing this, however, we are not doing great. This is a study that we did looking at how patients with laterality defects were being referred and evaluated in our center. Now, this was from 2009 to 2021, so it's a little bit old, so hopefully we're doing better now. But we found that for those, all the patients had laterality defects, and that should be a red flag for evaluating these patients, right? And so taking that into consideration, we looked at the other criteria for these patients and found that for those patients that had 4 of the criteria, the referrals were pretty good. We were still not evaluating all the patients, but very good. But if we look at the 2 or 3 criteria columns, we can see that we are missing a lot of referrals to pulmonary. And sadly, even when those patients are being referred, we're not always evaluating them. So the next step for this would be to educate the people who refer patients to us, like cardiologists and NICU doctors and general pediatricians, and also educate our pulmonary group into ensuring that these patients get appropriately evaluated. For other patients, the evaluation is going to be based on their clinical presentation. Of course, for patients with PCD, HACD, and bronchiectasis, we want to obtain cultures regularly. But also when there are concerns for active infection. Flexible bronchoscopy when there are concerns for airway anomalies, as well as for surveillance cultures. When there's concerns for structural lung disease and or bronchiectasis, we recommend getting a high-resolution chest CT with inspiratory and expiratory views. Swallow study or FEES for signs and symptoms of dysphagia, and an ultrasound of the chest for diaphragmatic movement disorders. All pulmonologists screen or should screen for sleep disorder breathing, and when the screening is positive, these patients should get a sleep study. And so the management is going to be based on the respiratory symptoms. And for patients who are diagnosed with PCD, we want to follow the PCD Foundation guidelines. But for the other patients that have HACD or bronchiectasis, we want to be thoughtful about initiating airway clearance, but we also want to do this in concordance with the other teams and services that evaluate these patients, like cardiologists, neonatologists, the cardiac ICU. Every center will do this a little bit differently, And so in our center, when CPT is not contraindicated, we'll usually use the best short-acting beta agonists and mucolytics. For the perioperative period and during acute respiratory illnesses, you want to have a low threshold for initiating airway clearance strategies as well as antibiotics. Longitudinal follow-up for the patients will depend on the respiratory clinical presentation, but for PCD, HACD, and bronchiectasis, we recommend every 3 to 4 months evaluation. So clearly, much research is still needed for us to try to understand how to best treat these patients from the respiratory standpoint. On a good front, primary ciliary dyskinesia is in a dynamic phase of discovery with better techniques for genetics, better disease characterization, and this will undoubtedly help the heterotaxy population. But we still don't know what the timing of the interventions should be like, which respiratory interventions are most effective, genotype-phenotype therapy correlation, and the long-term outcomes in lung function and quality of life in treated versus untreated heterotaxy patients with ciliary dysfunction. And so back to our patient, he was discharged 2 months post-op, followed up in the PCD clinic at 22 months of age. He presented with daily cough and nasal congestion, had a cold at the visit, but had otherwise been doing well. Exercise intolerance per cardiology was secondary to his cardiac pathophysiology. He had not had any ear infections, and his swallow study was negative for dysphagia. We obtained a CF throat culture that showed lactose fermenting gram-negative rods and continued airway clearance twice a day, with plans to measure nasal nitric oxide at his next appointment and a follow-up in 3 to 4 months. In terms of what his pulmonary diagnosis is, so we are between PCD suspected, PCD highly likely, and HACD. And so hopefully we'll measure nasal nitric oxide and be able to place him in one of these diagnoses. And in the meantime, we will keep treating him with airway clearance as well as a low threshold for the use of antibiotics. And in conclusion, patients with heterotaxy have particularly high rates of ciliary dysfunction. Ciliary defects are implicated in both laterality defects and impaired mucociliary clearance. Heterotaxy patients show more severe respiratory complications compared to other congenital heart disease populations. The clinical implication is obtain a pulmonary consult for all patients with heterotaxy and consider airway clearance therapy and close monitoring for infections in patients with heterotaxy. And Steve Sperging wanted me to add here the link to our now live page for the heterotaxy program, which is up and running. I don't know if it'll do its thing, but all right. And with that, I thank you for your time.